Hi, I'm Dr. Seth Sherman from Stanford University, and I'd like to demonstrate repair of a chronic complex lateral meniscus tear using NOVOSTITCH Pro. These are my disclosures. Note that I am a consultant for Smith&Nephew. The opinions expressed here are my own and based on my personal experience with NOVOSTITCH Pro in my practice treating patients and trying to save the meniscus. So this patient is a male football and track athlete. He suffered a contact type injury 1 year ago. He presented with worsening lateral-based pain, swelling, and mechanical symptoms. On examination, he had a large effusion. He had full range of motion with pain. He had tenderness along the lateral joint line with a grossly positive McMurray. He had otherwise stable ligaments. The patient's imaging studies demonstrate preserved joint spaces on the weight-bearing AP, PA flexion views, and merchant views as shown here. The patient also has subtle patella alta. We can see on his mechanical axis view on the far right that his weight-bearing line goes through the center of the knee and is symmetric on both the right and left side. MRI demonstrates complex tear of the lateral meniscus. His cartilage surfaces are unremarkable. His ligaments are intact. The patient was indicated for surgery given this complex lateral meniscus tear in an active athlete. Here we can see the meniscus tear, and we are probing it to get a sense of its configuration. This tear initially might have appeared to be considered a partial discoid. However, it really did not have the classic discoid morphology, and it just turned out to be a very large, complex parrot beak tear extending to the mid-body from the posterior root. We can see that this tear pattern really extends into the red zone. If we decided that this tear was not repairable and we trimmed it, it would basically render this athlete meniscus deficient, which would put larger loads on his convex lateral compartment, leading to breakdown of his cartilage and likely to a cascade of arthritic change over time. Here we can see that we are preparing the meniscus for eventual repair. We typically like to use a meniscus rasp. We can also use a shaver to debride to healthy tissue. What we can see now is using the NOVOSTITCH Pro through a contralateral portal, and the first stitch here is really trying to reduce the meniscus as much as possible. You can see that our first pass was through the actual meniscus that was anchored to the periphery, and then our second pass is through the apex of the parrot beak flap tear. When we maneuver and tie, this will reduce the meniscus into a much better position and set us up for either further stitches with NOVOSTITCH Pro or other all-inside device as needed to continue an anatomic reduction. With the NOVOSTITCH Pro, you do not need to use a cannula, and we tie these low-profile knots within the joint. We can see the initial apex is now reduced, and that actually brought the meniscus upward tilting. And so what I decided to do was use an all-inside device underneath the meniscus to bring it down into a more anatomic position. Once we passed that second stitch, this set us up for again using the NOVOSTITCH Pro. You can see how its nice low profile can get under the condyle, and its circumferential compression stitch can really reduce that peripheral meniscus to our parrot beak flap, as we see here. This is a nice vertical longitudinal component of our parrot beak flap tear, and this stitch here really sets us up for success, compressing that meniscus down in the posterior horn. After we're finished tying, usually with Revo type knot tying, then I'm really trying to assess the meniscus. Am I completely happy with the repair? And in this scenario, I think that we could use some more compression and anatomic reduction in the apex. It would be very hard without a NOVOSTITCH Pro to get this type of a bite. You can see I was using the probe to determine whether I had enough landmarks in order to get the job done safely without destroying the meniscus. And you can see how maneuvering the NOVOSTITCH Pro, using the targeting marks, I can really get the stitch exactly where I want it. And then again, using controlled tension on my tying, I can further reduce this meniscus back to anatomic location. At this point, I'm happy with the stability of the meniscus. It no longer appears extruded. I think that we're not aiming for the perfect reduction in this chronic case. We really want anatomic as much as possible overlap and compression, and then allow biology to do its thing. In these types of complex tears or radial splits or root tears, we really need to go slow with the rehabilitation. We're going to limit weight bearing. We're going to use a brace in this patient to avoid extrusion force on the repair. But you can see how at this point versus initially, that meniscus is in a very good position and has as good a chance as any to remodel and to repair itself, to reduce loads on that lateral compartment. In cases of isolated meniscus repair, I typically will microfracture the intra-articular notch. This, you can see, is just above the ACL, which is intact. In cases where we do ACL reconstruction, this step is often not necessary as we are drilling tunnels. But what we'll be able to see is that we can access the marrow elements. You'll see that these marrow elements actually elute from the bone marrow, and they will come downwards and gravity-dependent fashion will try to form an initial clot over that meniscus repair site. This will help to augment the biology for early scaffold formation and for remodeling and healing of this complex chronic lateral meniscus tear. So I hope that this case demonstrates why we want to err on the side of meniscus preservation whenever possible. Taking out this meniscus would have been akin to a functional or subtotal lateral meniscectomy, which would have led to disastrous outcome for this patient. We give him a chance for his meniscus to heal and give a chance to preserve the lateral compartment in this active athlete. I thank you for your attention.